Kumar. Thank you very much, Dr. Alok Kanungo, for giving me the opportunity to talk. The topic that Alok had given me to talk is where are we in the cure for type 1 diabetes? We had an excellent presentation by Oka Landmark, where he had clearly indicated the etiopathogenesis of type 1 diabetes and what are the pathogenesis that are important that may be useful for prevention. So in my talk, I'm going to talk about the various vaccine approaches that have been used for curing of type 1 diabetes. So what you see on the left is the normal pancreas with islets of Langerhans, and this is the pancreas that is affected in patients with type 1 diabetes due to insulitis. So from here, we need to move to here is what the cure for type 1 diabetes is all about. So this is the standard picture that has been discussed, displayed over the past 20 years in several forums. What happens here is that the people are born with genetic susceptibility. At some time point, as OK pointed out, there are environmental triggers. Then there is a detection of humoral autoimmunity, and they are either GAD or IA2 or both positive. And in this situation, there is a decline in the beta cell function until you reach 50% of beta cells availability when the intravenous glucose tolerance test becomes positive, and when the percentage of beta cells fall to 25% of what is available, then the abnormal oral glucose tolerance test becomes visible. So the onset of type 1 diabetes happens when you have something like 10% of beta cells left. And this is where you have further decline of the beta cell. And in this situation, you have what is called as honeymoon period. Much of the vaccines have been given at the time of onset, primarily to indicate that the preservation of 10% is very important. And in this preservation, you will avoid diabetic ketoacidosis. The reason why you have to intervene here is because the US FDA gives a clear restriction on when to intervene. But if you were to intervene at different time points, the percentage of beta cells that you will save is going to be bigger and bigger. And some of the recent studies are trying to address how to give vaccine in this particular people who have still quite a good amount of beta cell left, but are autoantibody positive. So where are we in the cure for type 1 diabetes? So in an ideal therapeutic goals for type 1 diabetes, you have to look for prevention of immune destruction, then preservation of beta cell mass, then the replacement or regeneration of the beta cells, and automated insulin delivery. So all these are happening simultaneously, and some are moving faster than the others. So when you look at the current approach for the cure of type 1 diabetes, the biological replacement of islet function has been achieved with pancreas transplantation and with islet transplantation. But there is a limitation here because over a period of time, the C-peptide level that goes up keeps dropping to a pre-transplantation time. In future, the human embryonic stem cells and the induced pluripotent stem cell may offer a potentially unlimited source of cells for islet transplantation. There are many laboratories that are working on this particular approach. Another potential strategy is to induce robust beta cell replication so that the regeneration of beta cells can be achieved. What it is, we will see in the subsequent slides. The immune interventions are being studied with the hope of arresting the type 1 diabetes disease process to either prevent or help preserve the beta cell function. So what is becoming very technologically advanced and sound is the mechanical replacement of islet function involving the use of glucose sensor controlled insulin infusion systems. So as all these avenues are pursued, sometimes what happens is when you come out with one publication or the other in different approaches, the media take it up and overstate the case, saying that, we have found a cure. It is going to help solve the problem of type 1 diabetes, giving quite a bit of a false hope to the patients as well as families of children with type 1 diabetes. So there is a limitation here in terms of how we extrapolate the results, but we need to have a larger study in order to confirm much of the results that we find in a smaller study. So many of the diabetes vaccines have been tested. Some of them, those tested are anti-CD3 antibodies, anti-CD20 antibodies, co-stimulation blocker, abatacept, and combination of low-dose anti-thymocyte globulin and granulocyte colony stimulating factor. These have all been tried, and let us see how these things look like in different situations. So this was a paper that was published by J. Schuyler in Diabetes Care in 2015, where he clearly showed that some of the smaller studies give a very good response between the treated one and the placebo one, where at the end of 24 months, the anti-CD3 treated individuals have a significant difference in terms of C-peptide preservation. So this is anti-CD3 monoclonal antibody. There is another anti-CD3 monoclonal antibody, which is otelixumab, which was also tried. There again, at the end of 18 months, the difference was statistically significant. The third one was the anti-CD20 antibody. CD20 is expressed in the B cells, whereas CD3s are expressed in the T cells. There again, at the end of 30 months, the significance is there, 0.01. But is getting down and down and down. So abatacept is a co-stimulation blocker that had reasonable p-value, but over a period of time, that also did not have much effect. So the approach that was used with anti-thymocyte globulin and GCSF has been done to preserve the beta cell function, and there is a very significant difference at the end of 1 year. But these are all small studies, and when you have to do these studies in a larger set of patients, you tend to lose some of the significant values that you find in the smaller studies. Here is a live table analysis showing the benefit of fully powered DPT-1 parenteral insulin trial despite perceived benefit in a smaller pilot study. In the larger version, no such significance were observed. So in the other studies that were published, putative benefit in a small subgroup in a GAD-alum vaccine trial that was not confirmed in 2 larger studies that were performed subsequently. And all these studies were published in very prestigious journals to indicate that the quality of the work is very, very superior. So when these vaccine approaches have been attempted and did not succeed, one of the approaches that was used by Diamond using GAD65 vaccine and vitamin D showed some promise. And what they did was they injected the GAD directly into the lymph nodes. So the GAD diagenode is the name of the study. GAD alum administered into the lymph nodes in combination with vitamin D in type 1 diabetic patients. So they had tested 6 adult patients who were 20 to 22 years of age. Each patient also received vitamin D in an oral solution for a period of 4 months. There was no apparent treatment-related adverse effects. And the immunological markers showed type 2 helper T cell upregulation with a stepwise increase in the Th2 markers. So there was a very good result coming out of direct injection of the vaccine into the lymph nodes. And this was published in the New England Journal of Medicine in 2017. And when you look at some of the results, the fasting C-peptide level goes up, the HbA1c comes down, the insulin dose also decreases in these patients, showing a very good response. So I haven't seen the subsequent results from this particular study involving larger sample set. So when these studies were going on, there was another study that has been happening at Harvard Medical School led by Denise Fossman, where she had used BCG vaccine for the prevention of type 1 diabetes. So what she concludes is that the BCG treatment or EBV infection transiently modifies the autoimmunity that underlies the type 1 diabetes by stimulating the host innate immune response. This suggests that the BCG or other stimulators of host innate immunity may have a value in the treatment of long-term diabetes. And she says that the best BCG vaccine to be used is the most antigenic strain called the Danish strain, which produces a very good regulatory T cell response. So how does this particular approach work? The TNF inducers and TNF receptor 2 agonists are all important players here. The induction of TNF through BCG vaccination or through selective agonism of TNF receptor 2 has 2 desired cellular immune effects: selective death of autoreactive T cells and expansion of beneficiary regulatory T cells. In a phase 1 trial in advanced type 1 diabetic patients, 2 BCG vaccinations spaced 4 weeks apart selectively eliminated the autoreactive T cells, induced beneficial Tregs, and allowed for a transient and small restoration of insulin production. So what she says is that the BCG vaccination breaks the autoimmunity And this breaking of autoimmunity is very important, that allows the ductal stem cells to transform into insulin-producing beta cells. So there is some more work coming out independently to show that the interplay between the BCG and Treg cells and its role to prevent and cure inflammatory diseases. So playing around with anti-inflammatory mediators generated by the BCG vaccination seems to be the one that is showing the beneficial effect in this approach. So when you look at Dennis Fossman's lab at the Harvard Medical School, it is becoming clear that the BCG vaccination is now in the phase 2 clinical trial. And once we have the results of this particular trial, then we will have much greater detail into the insight of giving BCG vaccination 2 doses 4 weeks apart. And this could happen in an established patients with type 1 diabetes. So when you look at all the approaches that had been used in preventing type 1 diabetes, one of the approaches that has been studied is the anti-inflammatory agents, and that seems to have an effect over a long period of time. The immunomodulation using anti-CD3 or anti-CD20 or co-stimulation blockage with anti-thymocyte globulin seems to have much good effect, but this effect seems to be short-lived, not going beyond 24 months or sometimes 30 months. So the increase in the Treg cells you promoted by the IL-2 or GCSF or Treg infusion has been another approach. So the diabetes-related antigen like oral insulin or GAD vaccine has also been tried. So when you look at all these approaches, what becomes apparent, as per J. Schuyler, who published this paper in 2015, says that individual approaches may not probably provide benefit, whereas if you could use combination of these approaches, it would make a lot of sense, and that would be very useful approach. But when we use these combination approach, we need to go back and do the clinical trials again in a combined form and in what dosage. All these things determine what will be the outcome of this particular studies. So combination of these vaccines could be potentially very useful. So when we look at those patients who are developing type 1 diabetes and then giving them the vaccine, when they have at least 10% of beta cells left, it would be ideal to have these vaccines given much, much earlier. And this particular study that was headed by Kevin Herold, teplizumab in the first degree relatives of patients with at risk for type 1 diabetes was tested. And this was published again in New England Journal of Medicine very recently in 2019, where they have done first degree relatives of patients with type 1 diabetes, not yet developed type 1 diabetes, but they are autoantibody positive, and they have done a randomized study where in one arm they have given anti-CD3 antibody and other arm placebo. So a phase 3 randomized placebo-controlled double-blind trial of teplizumab, and which is an anti-CD3 monoclonal antibody, was used. They are tested in 76 participants, and they have shown that there is a very good delay in the development of diabetes in these first degree relatives of patients with type 1 diabetes who had received teplizumab compared to the placebo. So this is the first study that had been done in individuals who are autoantibody positive but who have not yet developed type 1 diabetes, clearly indicating a stage in the development of diabetes where the beta cell mass is much higher than in individuals who have developed type 1 diabetes, where the beta cell mass is known to be something like 10%. So some of the advances that have been happening recently in a rapid pace is the cell replacement therapy, where they have used the stem cells, and these stem cells are generated from mesenchymal stem cells modified using inducible form of pluripotent approach, where they have the pluripotent stem cells. So this is a paper that was published very recently on December 21, 2021 in Cell Reports Medicine by the group led by James Shapiro. James Shapiro was the person who did the islet transplantation, mixed islet transplantation, more than 22 years ago. Now, this paper clearly shows that islets grown in culture that has been derived from the pluripotent stem cells is really beneficial, and they have tested 6 out of 17 subjects demonstrated positive C-peptide as early as 6 months. And these patients who had developed type 1 diabetes become insulin-free at the end of 6 months, as the follow-up study shows. And the most important point here for the success of this particular approach is that these beta cells derived from stem cells should be properly encapsulated and then given into the patient, either to a surgical approach where you wrap these encapsulated beta cells in the omentum of the patient so that there is a rich blood supply. And this rich blood supply is extremely important for the survival of the beta cell so that there is a continuous availability of insulin from these beta cells in response to the glucose line. So there is another group that is working in Harvard Medical School led by Doug Melton, where the promise of stem cell-derived islet replacement therapy he is discussing in this particular paper. So the approach requires pluripotent stem cell, either it could be embryonic stem cell or inducible form of pluripotent stem cell until it reaches the endocrine cell, where you have the insulin-producing or the islets that could have the alpha, beta, and delta cells as well. So this involves in vitro studies in human islet function, then transplantation with physical encapsulation of immune protection, then transplantation with biological or genetic manipulation of the immune protection. This is the stage where they are trying to use CRISPR-Cas technique that won the Nobel Prize 2 years ago to see whether they could do some more magic here by making these beta cells survive longer without the susceptibility genes present in them. So with this, I conclude my presentation. There are several approaches, but we need a large-scale study. We need a combination of vaccine approach that again needs to be studied in phase 3 clinical trial. And there is a hope, but it's extremely expensive. And the number of type 1 diabetic patients who could be tested are also not so many for us to go and do these testing. So with this, I end my presentation. I thank you very much. And here are the various volumes of the Immunology of Diabetes published by the Annals of New York Academy of Sciences, where many of you can go and see what to expect. So thank you very much, and I'll be happy to take questions during the panel. Bye for now. Sayonara.